I wish to welcome all the participants, and I hope that we will have a lively discussion. I wish to tell you why we think that Healthy Baby Project is needed. And the underlying rationale is that the incidence and prevalence of chronic non-communicable diseases have increased dramatically in most developed countries after World War II. And we can see that a similar process is also starting up in developing countries. Recent research data suggests that the roots of these diseases are to be found in infancy and early childhood, and there are also data indicating that these immune-mediated diseases may be actionable. So the early identification of risk individuals and the implementation of methods to stop the initiation of the disease process or its progression to clinical symptoms offers new prospect the prospect that these diseases might be preventable. And we are focusing on these three diseases or groups of diseases: type 1 diabetes, celiac disease, atopic diseases. And as most of you know, Finland has the highest incidence of type 1 diabetes in the world. This shows data from 2011, and we had an incidence rate of 64 per 100,000 children under the age of 15 years by that year. And as you can see, there is a huge difference depending on the geographical area or countries. So actually there is a 100-fold difference when you compare data from China and data from Finland in relation to type 1 diabetes. And we also pass Sweden with almost 50%, which is Sweden is the second, has the second highest incidence. What we have also learned from Finland, that the incidence in the early 50s was 12 per 100,000 children, and the peak incidence rate we have seen in 2006 when it was 65. After that, there has not been any further increase, but we have reached a plateau around 60. So this shows that the rate has increased more than fivefold in a time period of about 53 years. And of course, that tells us that this cannot be due solely to genes, as genes change slowly over many generations. This must in some way be related to changes in the environment and living habits in the Finnish society. Of course, we can say that a similar increase has also been witnessed in most other developed countries, but we have the figures for the longest period of follow-up. Here we can see the age distribution of newly diagnosed diabetic children, and as you can see, after the first 2 years, the proportion contributed by each age group is very similar. We do not have any clear pivotal peak, as is told in textbooks. We haven't seen such a phenomenon for the last 40 years. Then the rate levels off after the age of 12 years. We also made a small comparison between Finnish children and Somali children living in the Helsinki area, since the Somali children is the largest group of immigrant children. And what this showed, that the prevalence of type 1 diabetes was even a little bit higher than in the original Finnish population. This is not a significant difference, but when we look at the data on the incidence of type 1 diabetes in these two countries, there is a very low incidence, and I think that this is relatively reliable data although the situation in Somalia is, of course, from the function of the society, completely different. But I think that this is a strong indication that the Finnish environment is truly diabetogenic. What we know about the development of type 1 diabetes is that we have as a bottom line the genetic susceptibility, but genes do not cause type 1 diabetes. Genes allow the development of type 1 diabetes. We think that there is an exogenous trigger event that starts the disease process, and then when about 20 to 30% of the insulin producing cells is put out of function, you get symptoms of hypoglycemia and type 1 diabetes. And we have asymptomatic period preceding the clinical diagnosis. The duration of that is highly individual. If diabetes is diagnosed in childhood, it's about 2.5 to 3 years, but we have seen cases where we have the appearance of autoantibodies in infancy and clinical presentation at the age of 1 year. We have also seen the appearance of autoantibodies at the age of 10 and clinical presentation at the age of 31. So there is definitely a high variation there. Type 1 diabetes is considered as an autoimmune disease, and a sign of that, we have the disease-associated autoantibodies that appear during the asymptomatic process. And the first signs of decreased insulin secretion can be observed when you give glucose intravenously and measure the insulin response, and you see a reduced first phase insulin response. We also think that there is a driving antigen pushing the disease process forward. Draw here a similarity with celiac disease, where we know that gluten is the driving antigen. So this is staging of type 1 diabetes, and this is something that is introduced about 6 years ago, and we have 3 stages. Stage 1 represents a child with signs with the diabetes-associated autoantibodies, but the normal glucose tolerance. Then we have stage 2, where we, in addition to autoantibodies, have dysglycemia, and stage 3 represent clinical disease. And I think that this is a useful approach when you consider the possibility to intervene. Here you can see diabetes-associated autoantibodies at the time of diagnosis. And as you can see, we have a majority of the children testing positive for various autoantibodies. If we look at the number of autoantibodies, we have only about 2% who have no detectable autoantibodies at diagnosis, and the majority test positive for 3, 4, and 5 autoantibodies. And these autoantibodies can also be detected in, for example, SIBs of newly diagnosed children, can also be diagnosed in the general population. Here we can see that we have something between 4 to 8% of the SIBs testing positive for autoantibodies. At numbers or detectable autoantibodies, we can see that about 6% test positive for a single autoantibody, and about the same proportion for multiple autoantibodies. That means 2 or more autoantibodies. And if you test positive for 2 or more autoantibodies, you definitely have a substantially increased risk for progressing to clinical disease. And this is shown on this slide, where we can see that if you test positive, this is based on studies from Finland, Germany, and Colorado. And it shows that if you test positive for 2 or more autoantibodies, you have a 70% risk of progressing to clinical disease over the next 10 years. One issue that has been raised recently is that type 1 diabetes is not a homogeneous disease, and one aspect of heterogeneity is defined which antibody appears in a pre-symptomatic period during the disease process. This is from the trigger study showing that in about 47% insulin autoantibodies are the first antibodies, in 42% GAD antibodies, and there are less than 10% testing initially positive for zinc transporter antibodies or IA2 antibodies. This has resulted in the suggestion that we had two major endotypes in type 1 diabetes, one where insulin autoantibodies appears first, where we have an early sharp peak of seroconversion during the first years of life, and the other endotype is then where GAD antibodies appear as the first autoantibodies. There are also indications that Coxsackie B virus infection could trigger the IA first endotype. This is associated with one of the predisposing HLA genotypes or haplotypes, DR4, whereas DR3 positivity is associated with GAD antibodies appearing as the first autoantibodies. This slide shows the appearance of insulin autoantibodies and GAD antibodies in DIP study, which is our Finnish birth cohort study, where we follow infants with increased risk for type 1 diabetes up to the age of 15 years or diagnosis of type 1 diabetes. This shows that we have a very steep peak of insulin autoantibodies appearing during the first 3 years of life, whereas the distribution of seroconversion to GAD autoantibody positivity is much broader, and it continues up to puberty. We also know that the prevalence of celiac disease has increased considerably in Finland. So here we compare the prevalence of type 1 diabetes starting for early 50s up to year 2000. And here we can see the prevalence of celiac disease. And as you can see, these are almost parallel, these curves. We have the concept, the celiac disease iceberg, where we have clinical disease at the top. Then we have silent celiac disease. We may have celiac disease latency. And then, of course, we have healthy individuals. And here, the genetic susceptibility plays an important role, since about 80 to 90% of those with celiac disease carry the DR3 DQ2 haplotype. Diagnostic criteria of celiac disease has also recently changed. So previously it was always like that you have to take a duodenal biopsy to confirm the diagnosis. Now, if you have the right genotype and high tissue transglutaminase antibodies, then you can make the diagnosis based on that, and you have to perform a biopsy only in those cases where you have the right genotype and antibody levels below lower antibody levels. Then, if you consider atopic diseases, we have the concept of the atopic march, starting in infancy with atopic dermatitis and food allergy. Then, at preschool age, allergic rhinoconjunctivitis emerge, and later asthma in school age or at adult age. Here we can see the prevalence of allergic symptoms at the age of 3 and 5 years in Finnish children. So as you can see, about 30% have symptoms of atopic dermatitis, 30% wheezing, some of those develop later asthma. Food allergy or suspicion of food allergy has been reported about 1/5 of 3-year-old children. You can see that the prevalence is a little bit lower at the age of 5 for food allergy, and actually also for the other allergic symptoms. Here you can then see the prevalence of allergen-specific IgE responses and positive skin prick tests at the same ages. So among the 3-year-old children, 46% have at least one allergen-specific IgE increased. If you look at skin prick tests, you get the positive reaction in about 22%. And in 5-year-olds, we have about the same proportion with at least one positive allergen-specific IgE, and 45% have a positive reaction in skin prick test. That does not necessarily mean that the child has a atopic disease, since a proportion of these children have no symptoms. But in any case, allergic symptoms is very common in Finland, as also in other developed countries. Then if we consider what kind of predictive tools we have available currently. For type 1 diabetes, we have the genes and genetic risk score. Family history gives some information of an increased risk, and the disease-associated autoantibodies tell more about the risk. For celiac disease, we have the same story with the genes plus the family history. But of course, a majority of those who develop celiac disease or type 1 diabetes do have a negative family history. And then in celiac disease, we also have disease-associated autoantibodies. In atopic diseases, family history gives some information, and you can measure allergen-specific IgEs and also perform skin prick tests as shown previously. When you then think of new predictive tools, so you could look for tools with better performance characteristics. That means higher disease sensitivity or higher disease specificity. You may use new types of biological samples. Most of the current biomarkers are analyzed from serum or plasma. There could be an option to analyze from, for example, saliva. You can look for predictive tools that give a signal earlier than the current predictive markers. Then we have the issue of developing tools that can predict the timing of the clinical disease. Then we have the question of costs. We have cheaper methods, and then we have scalability. And since we have a vision that this type of prediction could be integrated in the Finnish well baby and well child system, so then that means that one birth cohort in Finland is currently about 50,000 children. If we then think of potential preventive measures, we could think of preventive drugs or vaccines, preventive foods, lifestyle changes, environmental changes, and among those, an increasing biodiversity. If you consider prevention of an immune-mediated disease, then we can classify that into primary prevention. In the case of type 1 diabetes, that means that we wish to prevent the disease in those who carry genetic susceptibility, but have no symptoms of or any signs of the disease. Secondary prevention refers to methods to prevent progression in those with signs or positive predictive markers to prevent the appearance of clinical disease. So here we have an example of a drug, and this is the first drug that has been shown to affect the disease process in those at risk for type 1 diabetes. So the individuals including in this study represent stage 2. They tested positive for multiple autoantibodies and had dysglycemia. And the drug used in an anti-CD3 monoclonal antibody, teplizumab. And this slide shows that by this treatment, that is a one-time treatment of 14 days, you can delay the progression to clinical diabetes with more than 2 years. And I think this is an important concept from that point of view, that this is the first example of the possibility to intervene in with the disease process. So this is an example of secondary prevention. Then we have in our DIP study shown that there is an association between enterovirus infections and the appearance of the first autoantibodies. So here we had a clear overrepresentation of enterovirus infections in the 6 months preceding the appearance of the first autoantibodies. There are more than 100 enteroviruses. Therefore, we analyzed neutralizing antibodies to 40 common enterovirus serotypes. And what we did see was that Coxsackie-B1 was associated with an increased risk of autoantibodies and also progression to type 1 diabetes, whereas 2 other Coxsackie-B virus, B3 and B6, were linked to a decreased risk. What was interesting here is that all those with an effect on the risk belong to the same family, the Coxsackie-B family. And we have also looked at that, whether there is any difference between the insulin autoantibody first endotype and the GAD antibody first endotype. And we saw that the risk effect of the Coxsackie-B1 infection was seen in the insulin autoantibody first endotype, not among those who developed GAD antibodies first. So this could suggest that preventive Coxsackie-B vaccine could decrease the risk of type 1 diabetes among those who develop insulin autoantibodies as their first autoantibodies. Recently, we have looked at the association of cereals, dietary fibers for the development of autoantibodies and type 1 diabetes. This shows that we found an increased hazard ratio for development of autoantibodies related to high intake of gluten without adenine. So this is cereals, domestic cereals excluding oats. If we include oats, we still have even a little bit higher hazard ratio. And if you adjust for energy, you still see a significant increased risk for seroconverting to autoantibody positivity associated with a high intake of these glutens. And that is also true for progression to type 1 diabetes, both for gluten without adenine and gluten with adenine. So this is somewhat surprising to see, especially when you exclude adenine, that there is when you include adenine, that you have a clearly increased risk. You also saw an increased risk in relation to dietary fibers. The only type of food that was not associated with an increase was rice. I have to say that this is preliminary data. They have to be confirmed in other studies, and some such work is going on. If you look at the median intakes of these cereals from the age of 6 months to the age of 6 years in Finnish children, you can see that the consumption of oats increased during the first year, but then decreases. Consumption of rice is very low. Intake of wheat is increasing steeply up to the age of 6 years. Even for rye, you can see an increase, whereas there's no increase for barley. And if you look at gluten without adenine, that is a clear increase, and that is due to the substantial increase in the intake of wheat. True also for gluten with adenine. And if you look at the dietary fibers after the start at the age of half a year, it's increasing during childhood. Usually, diet rich in dietary fibers is recommended to be healthy. This, of course, caused some question marks. This is an experimental study in NOD mice, model of autoimmune diabetes. So here, Australian researchers used acetylated starch or butyrylated starch and looked at how that affected the progression to autoimmune diabetes. And what they did see is that when you use these acetylated and butyrylated starch, you have substantially slower progression to autoimmune diabetes compared to normal purified diet. So I know that the studies, human studies are planned, and there are studies going on to look at how people accept this type of food. Then we looked at the effect of pets on the risk of development of autoantibodies, and what we found was the exposure to an indoor dog during the first year of life decreased significantly the risk of autoantibodies. We also saw that for type 1 diabetes, whereas indoor cat and outdoor cat did not affect the risk. And this indicates that we know that since the indoor dog goes out quite frequently, so that will increase the biodiversity in the home. So we think this is an effect of increased biodiversity conferred by the indoor dog. Then if we look at the gut microbiota, we know that the gut microbiota has an important role in health and disease in human. We looked at a few children who progressed to type 1 diabetes and followed them from birth up to the age of 3 years. And we found that those who progressed to clinical diabetes had decreased diversity or their microbiota, but that appeared after the appearance of autoantibodies, suggesting that this could have an effect on the progression from autoantibodies to clinical disease. We think that the intestinal microbiota play a role in the development of autoimmune-mediated diseases. So the first step is that we have poor immune education by the gut microbiota in the infant period. Then that results in an acquired susceptibility, immune-mediated diseases later in childhood, dysbiosis, and decreased microbial diversity ending up in clinical disease. We have done a study comparing Finnish young children and children living in Russian Karelia and Estonia. This shows the abundance of Bifidobacterium longum in the intestinal microbiota. So that is in blue here. And then we have the incidence of type 1 diabetes in these countries in orange. And as you can see, there is a clear relation between these two phenomena. And actually, Bifidobacterium longum, Bifidobacterium infantis has been described as a lost bacteria in developed countries. And it has been shown that it has a series of effects that would possibly have positive effects on the gut microbiota, on the immune education, and even on the pancreatic beta cell survival. That should decrease the risk of type 1 diabetes. And therefore, we are interested in an intervention study with this Bifidobacterium infantis. There is also a study looking at the use of probiotics and the development of autoantibodies. That is the TEDDY study, which showed that you had, if you used probiotics during the first month or the first 27 days of life, you had a reduced risk of autoantibodies, and that was seen especially in the high-risk children, those with the high-risk HLA genotype. Other important aspects to the Healthy Baby project is the cost effectiveness analysis of prediction and prevention. If we have the idea that this could result in a program that could be integrated into healthcare systems, the healthy baby, the well baby and well child clinics activities, then we have to show that it should be a cost-effective activity. And then also the communication with the families taking part in the research projects is important. So the vision is that this activity should generate a predictive and preventive program with a possibility to integrate that in the healthcare system. And of course, such a program can also be exported as a complete ecosystem or as components to both developed and developing countries. Thank you.